I'm Tessa Gardner here to this conference. I've been after her for 3 years to try to get here, so I'm really happy she's here. And the reason I was so excited about asking her to come speak is because of that wonderful chapter that many of you, I'm sure, are aware of. It's called Lyme disease, and it's in a book, Infections of the Fetus and the Newborn, Infectious Diseases of the Fetus and Newborn Infant, edited by Remington and Klein. It's truly an awesome chapter with more references than I've ever seen in any chapter. Dr. Gardner is a pediatric ID consultant in St. Louis. She's assistant professor of clinical pediatrics at the Washington University School of Medicine, and she's going to talk to us about pregnancy and Lyme disease.
Thank you. It has been 3 years that I've been intending to get here. It was always during spring break or Passover or something, so I'm very pleased and delighted to finally be able to talk to you. I'd like to thank Dr. Fallon and the Lyme Disease Foundation for inviting me. Now, I'd like to...
Is it on PowerPoint? You got it. You got it.
Okay, good. Okay. I'd like to begin by just putting into perspective the number of potential cases of Lyme disease in pregnancy and possibly which would perhaps result in congenital transmission of Lyme disease, because it isn't actually very many that we would expect to occur on a yearly basis. And if you look at this slide, that basically is published data indicating the number of cases of Lyme that occur in the United States and an estimation of the cases in Europe in 1998. If you then use the percentages that are reported in the literature of how many of these cases of Lyme disease would occur in women, then in the United States it's around 40 to 50%, so that gives you 7,000 to 8,000 cases in women. In Europe, it would be about 20 to 40,000 cases occurring in women. The female incidence is a little higher. If you then look, how many are in women in the childbearing years? And this data is also from various articles in the literature where they divide up the incidence into decades of life. And so using these numbers for both the U.S. and Europe, you can kind of do an estimation, and you get about 1 to 3,000 cases of Lyme disease in the United States occurring per year in women in the childbearing years, and a lot more in Europe. Now, what we don't know is how many people with Lyme disease, of these potential patients who are women in the childbearing age, how many actually are pregnant? So I just, for fun, did some quick, guesstimations here. And I said, okay, what if we overestimate and we say maybe 1 out of 4 people women in the childbearing age is actually pregnant, which I think is an overestimation. Then you would actually, your number would come down to 1/4 of what it was before, so we're talking about 1 to 3,000, so that comes down again. If you then ask the next question, of the number of pregnant Lyme disease patients who are treated, untreated, or inadequately treated, how many are untreated or inadequately treated? Because those are the ones that we would be most concerned about having a fetal complication. And so that further decreases the number. And I just figured if I said, well, maybe 10% of the patients with Lyme disease are either not treated or inadequately treated, because we're basically mostly here talking about acute onset of Lyme in pregnancy, which most of the time is going to be correctly diagnosed. So, and then if you go down here and you say, okay, I know there's a debate about that, but I'm saying the way I'm looking at it is a pregnant woman with acute onset of Lyme disease who gets an erythema migrans lesion and goes to the doctor and they look at it. I'm not talking in this estimation about people right now with persistent forms of it. I'm just doing this as a sort of an exercise in how many patients could we maybe see. And at the bottom, what is the annual number of normal and abnormal outcomes of pregnancies complicated by Lyme disease? And by doing all these kinds of guesstimation calculations, I came out with, of the total 16,000 to 17,000 cases in the United States of Lyme disease per year, probably somewhere under 0.25% might be calculated to be expected to have some transmission of congenital Borrelia burgdorferi if we assume something like a 50% attack rate in pregnant women who aren't treated well. Now that's not, we'll have some data later on that will speak to that, but that just, when you take that number and you run it through this whole sequence, you end up with an estimation of somewhere around 40 cases per year in the entire United States that we might be trying to look for. If you figure how many cities we have in the highly endemic areas, we're talking about 0 to 2 or to 1 or 2 cases per city, per major or moderate or major sized city. So each individual physician or hospital may not be very likely to see any or more than 1 or 2. So that is going to contribute to somebody's assumption of how rare it is. And we have to remember that we aren't really expecting each individual doctor or center to see that many, even if it does exist at a high enough rate that we would expect to see it. So that's just sort of a fun thing I did in terms of calculations. Now I'd like to go through and talk first about over the years, people have referred me patients with gestational Lyme and also children, infants, neonates with various and sundry difficult to figure out infections. And some of those, in fact, have turned out to have Lyme, both the mothers and the babies. And so that's actually what I'd like to present today are some of these patients that I have seen that over the years have triggered me to look into the medical literature of the 20th century. I went all the way back to 1900 to try to see what was in the literature that could be culled out of it to help try to see if there was a syndrome or a description of patients that might be at risk to have congenital transmission or congenital acquisition of Borrelia burgdorferi from a pregnant woman with Lyme disease. And what did emerge as I did that is I included in this chapter there are over 800 references in this chapter. The book actually cut out another 400. It ran out of space. But that's why I'm not going to actually be referencing each article directly from the literature. They're all listed in here in a well-organized fashion. So if anyone wants to look up the references from which I have culled patients that I felt had congenital transmission or adverse responses to gestational Lyme, you can look in that chapter. And what I did then was I took the patients that I personally had seen that I felt had adverse, normal and adverse responses to gestational Lyme, the products of pregnancies. I took those patients and I also took the patients in the literature for which I could track an individual outcome of a woman with gestational Lyme. Some of the problems are that the patients who are enrolled as cord blood you don't always know what the follow-up would be. You don't know how many were lost in the miscarriage pre-delivery. So, and also patients that are enrolled in some of the large studies at the first prenatal visit lose some of the patients if they miscarry later and they are lost to follow. So you don't know, you can't identify the outcome of all those patients. And some of them, if they had a miscarriage prior to the first prenatal visit, you wouldn't even pick them up. So what I did when I put together my chapter and the numbers was I tried to track each individual outcome, and I looked at every pregnant woman in the literature that I could find, and I tried to identify who I could reliably say had an outcome, whatever the outcome was. And then I tallied those up and tried to use that to give me a hint as to whether there were any patterns of transmission or presentation in the outcomes of these pregnancies. Now, I'd like to to run through, I did find some patterns, and these again are not intended to be definitive descriptions of anything like a syndrome. And in fact, I would say that I would prefer to call the entity that we're talking about congenitally acquired Lyme borreliosis rather than congenital Lyme syndrome, because a syndrome is usually characterized by a pathognomonic abnormality or anomaly or something that's reproducibly present in most cases that clearly identifies that as something that's been teratogenically caused. And I don't know that we can say that yet with Lyme. I think we have so few cases that we need a larger study that encompasses really all of North America, which I'll be talking about at the end, to try to catch as many potential patients as possible, to try to develop case definitions of what it is that we should be looking for in this, in the products of gestational Lyme pregnancies. Now, I'd like to just run through very quickly. I know this is going to be a lot of things, but there are basically there are some patients who have Lyme disease in pregnancy who will give birth to completely normal children. And I have a couple of examples that I'd like to just run through. So I'm calling this the asymptomatic infant with gestational Lyme borreliosis exposure. Here's an example. A 26-year-old woman had untreated last trimester gestational unilateral Bell's palsy, followed by a 2-year period of protracted, persistent Bell's, headache, meningismus, memory deficit fatigue, recurrent erythema migrans, lesions, and polyarthralgias. And this all went on for 2 years before she saw me, because I saw her child for another reason, and I got the history. And she turned out to be seropositive and was treated and did exceedingly well and is fine now several years later. But in the meantime, because she got this to begin with in the last part of her late third trimester, she delivered a baby. This baby was completely normal at birth. She also delivered another baby a year later, prior to the diagnosis being made, and that baby also was normal at birth. So these two little boys were completely normal at birth. Both of them, between 5 and 7 months of age, were treated for either a rule-out sepsis meningitis episode or a pneumonia of a respiratory tract infection. And they were treated with a week or two of IV or PO antibiotics, and they did very well. And then, in addition, in the year or so after this, the little boys, one of them had recurrent respiratory infections and otitis, and so he had a lot of courses of amoxicillin for that reason. And the other one had another episode of a respiratory infection and had another course of amoxicillin. So when I saw these kids, one of them was in the hospital for the second episode of his respiratory infection, and I just got this incredible history. But these little boys were seronegative, and I wasn't set up at the time to do the in vitro lymphocyte proliferative assay, which at some point I'll probably call them back and do. So I wasn't able to confirm any seropositivity of any kind. And they were doing quite well, and so I did not retreat either of these boys. And several years later, they're doing perfectly well, as is their mother. Their mother I did treat. So that's an example of a good outcome from an untreated mother. So it does happen. Now the second, I need to back up. No, back up. Back up. Okay. Now I'd like to talk about mild. What I've done is I've grouped patients. The data that I pulled together seem to group these patients seem to suggest that they would do well being grouped in the form of early and late disease, mild and severe. Now this isn't the definitive final word on it. It's just a sort of a working definition that I'm using right now. So mild early congenitally acquired Lyme disease, I'd like to just give you an example. And a 38-year-old woman developed acute early first trimester erythema migrans, followed by a flu-like illness and disseminated rash. And she was promptly diagnosed because she came to see me right then, actually. within 24 hours of getting the rash because they thought she had rubella. And she didn't have rubella, she actually had Lyme that she had acquired outside of Missouri. And so she was treated, she seroconverted with the East Coast tests, and she was also lymphocyte proliferative positive. And she was treated promptly with IV antibiotics, did beautifully, and delivered a perfectly healthy, normal baby, who I then also tested with serology, and she was negative, and with the in vitro lymphocyte proliferative assay, and she was positive. And this little girl had a very mild, this baby had a very mild CSF pleocytosis, and she had very impressive inguinal adenopathy. I had never seen anything like it. And so I said, okay, she's lymphocyte proliferative positive. I went ahead and gave her 2 weeks of IV antibiotics, and the inguinal adenopathy went away. And she perked up, actually. We hadn't realized that she was a little listless to begin with. But she did fine, and now 6 years later, actually, I think I haven't seen her for a couple of years, but when I saw her last at 6.5, she was a perfectly bright, fine child, and her mother was also well. So that's a good happy ending when prompt diagnosis and prompt therapy is accomplished. There's another Now I'd like to go to a little bit more severe a lot more severe presentation. And this is a baby that I was asked to see in the NICU at my hospital. And this baby was severely ill, was on a ventilator, and was being treated for severe rule-out sepsis, DIC, had a blueberry muffin picture. Let me actually have the next, I need the slide now, the photograph slide. It's on the slide. Okay, this baby, as I said, had thrombocytopenia, DIC, had hepatosplenomegaly, had huge inguinal adenopathy again. And this is now the second one I'm saying, maybe there's something to this inguinal adenopathy. And she had a dilated cardiomyopathy, you can see on here, huge heart. She had the organomegaly. She had a very low APGAR. She had a patent ductus, which is not that uncommon, but she had a meconium ileus, which you can see here, and that was very impressive. And then she also had a very interesting thing. She had celery stalking on the long bones, which is something that we see in congenital viral infections. And we, of course, worked her up for all of those, and she didn't have any of those. And I don't think the celery stalking actually shows up here, but what you can see is these arrows point out these white bands that go across. They're really prominent here. And the pediatric radiologist called me up and was very excited. He said, I've never seen anything like this. This kid has what we call sclerotic metaphyseal bands. Okay, so what does that mean? It means, well, we see it sometimes in syphilis. But she didn't have syphilis. This is what happened as we treated her with antibiotics. This was about a week, I think maybe a few days, and this was a few more days, and this was a few months. And these bands just disappeared. That was interesting. I didn't know. I didn't know what they meant. She also had split sutures and a bulging fontanelle. She had elevated CSF protein, and she had flexion contractures of her large joints. This was a very unusual presentation, and it turned out that the mother had first and second trimester sinusitis, but she had multiple tick bites in the first trimester, not in Missouri, but lots of tick bites, and then had these episodes of very severe sinusitis for which she got some oral antibiotics for a period of not that long, a couple of weeks or something. And then she didn't have any other antibiotics at all, and she was fine. But in getting the history of the tick bite and everything, I went back and I thought, well, we've looked for everything else. We couldn't figure out what this baby had. She was getting better with the IV ceftriaxone. I actually think we used cefotaxime as well as Ambien. And I ended up she was antibody negative, she was seronegative by the standard antibody test, but she was in vitro lymphocyte proliferative assay positive to Borrelia burgdorferi. So that was very interesting, and she got dramatically better. I saw her last when she was about 2.5 years old. I probably should call her and see her again. And she had, at 9 months, we sent her home from the hospital at 2 months, and she had done beautifully. All of the bands went away, the adenopathy went away, they fixed her heart, her brain got better. She did, her DIC recovered, and she did very well. And she went home at 2 months in very good condition. And then I saw her at 9 months, and I saw her periodically, but at 9 months, she had a mild developmental delay, and she had a little growth retardation. Her head was a little small, and she had actually become seropositive at that point. And she had some lower extremity spasticity, and her mother didn't think she was doing as well as she had been doing for the previous few months. So at that point, since she had become EIA, and I don't know if we did a Western blot at that point, it was a while ago, she became seropositive. So I treated her with a not terribly long course of IV antibiotics. It was probably 2 or 3 or 4 weeks. And she did very well, and then I saw her again to about two years after that, and she was a fine, normal little girl. So I think that's an instance of someone where they present like a severe rule-out sepsis with DIC, fulminant DIC, and end up with both a positive Lyme serology and positive in vitro lymphocyte proliferative assay, and in fact respond to antibiotic therapy and do well after that. I'll need to go back to the PowerPoint. Now I'd like to talk about severe. This was a summary slide of the things that I would say one would want to look for, and this is just from looking at all the cases that I've looked at. Again, this is not a definitive definition or case definition of the syndrome, but I think that what I found when I reviewed all of these other cases from the literature was that this tends to occur after maternal gestational Lyme in the first or second trimester. And these are some of the symptoms that I put together that see that this patient had many of them, plus there's some others from the literature. Now, the last entity is late congenital Lyme. And this, actually, at this point, I'd like to have the other photograph slide. Now, this little boy, I was asked to see him because he was a completely floppy child like this. He was 2.5 months old in this picture. And the pediatricians were convinced that he had some sort of a congenital infection. And they tested him for everything that they knew the name of, which was a lot, and he tested negative for every single thing that they had thought of. So that's when they called infectious disease. So, and we got an x-ray. As part of, we were looking for celery stalking. And this child occurred after the one that you just saw. And the radiologist called me again and said, you remember that kid that we had 2 months ago that had the metaphyseal bands? And I said, yeah. I said, well, I think this kid has the same thing. So these are a little wider, but you can see there's some white in there. And as you go down, this was about several months afterward. And within, this was the 2.5 months. This one is like 5 days and 6 days, and this is several months later after antibiotics were started. And the transverse metaphyseal bands, whatever that means, just melted away. This child had diffuse adenopathy. He had hepatosplenomegaly. He had a very obvious strabismus and a facial cranial neuropathy there. He was completely hypotonic. He presented actually with hypotonia and recurrent aspiration pneumonia. And it turned out what he ended up having was a thyroglossal, I think it was thyroglossal cranial neuropathy, and he couldn't swallow. And he didn't eat until he was about 3 years old, and now he's a fine and healthy 10-year-old. But he also had a rash. I think you can see it's fairly bumpy. Actually, it's almost easier to see in a black and white because you can see the texture of it. It's a bumpy, very dense rash. He had this on his trunk and also on his distal extremities. And here he is at about 2.5 or 2 years old. You can see he has a little gastrostomy button there because with this neuropathy, he really couldn't, he aspirated every time he put anything in his, any food or drink or water. So he was actually fed completely through his gastrostomy until he was old enough to really understand and go to swallowing therapy and cooperate. And then he had his first cookie in my office, and ever since then he was eating a lot. Now he also had an interesting story in that I treated him with IV ceftriaxone, and he did really very well. And then we took him off of it after the several-week period of time. And his skin was clear and everything, he was just doing great. And then he started to reverse, and he started to get floppier again, he got the rash back, his liver got big, and he started having aspiration pneumonias again. And what ended up happening was that he had so many episodes of aspiration pneumonia that we ended up keeping him on prophylactic amoxicillin until he was about 1.5 years old. And I think that, you know, he needed it for the recurrent aspiration pneumonia, and he did beautifully on it. And then finally, when he got to be 1.5 years old and he was, walking around and doing great, I just took him off the amoxicillin, and he was fine until he was about 8. And then at 8, he was in a normal school with some special language aid because he had his mouth, he had to learn both to eat and to talk properly. But he was doing very well, and he was reading and spelling. And then his mother, I saw him every 6 months. And his mother, I would have him tested extensively every 6 months by the psychometrics and speech therapy and all the people at the special school district. And everyone all together started realizing, in a 6-month period, that he was losing some reading, that he would lose some consonant sound, he would lose some spelling, and he would lose some reading, he would lose some phonics. And then he got polyarticular arthritis in the ankle and knee. And then he had a seizure. It was I don't think it was a grand mal, I think it was a patino or something. And so at that point, he actually developed a few bands on his Western blot. He was also positive by the lymphocyte proliferative assay for Burgdorferi. And his mother, who had Lyme extensively throughout her pregnancy, which I'll tell you about in a minute, was seropositive. It was from the East Coast in Maryland. She was seropositive by every test you could do, and also positive by the lymphocyte proliferative assay. But so with this together, I retreated him, and he relearned how to spell, and he relearned how to read the consonants and everything that he had lost. And the arthritis went away. He was seeing an orthopedic surgeon. And he stopped having seizures, and he's now about 10 or something, and I'm due to see him again, and he's in normal school and normal classes, and he's very cute, and he does fine. And he eats normal food, and his gastrostomy is out. So it's had a very good outcome. But I think that this type of patient is one that may be hidden and wouldn't necessarily be easy to find unless you were suspicious of it. Now this is just a summary of what I think one could look for in terms of patients with late congenital Lyme. It's generally, I would expect it to be a subacute process, maybe to have some developmental delay, meningoencephalitis, failure to thrive, growth retardation, things like this. These are non-specific kind of findings. But I think these are the things that you would have to consider to not miss some of these patients. Now, this is a slide that actually I adapted from the data that I put together for the chapter last fall in the big book. And what I did is I now from the literature found, there actually are a few more that came out in the past year that I haven't added in, but basically there are about 260 cases for which the outcome of the individual episode of gestational Lyme borreliosis was noted, able to be definitively assessed. And of these total, about 1/4 had adverse outcomes of these pregnancies. So that means 3/4 actually had good, normal outcomes. If you take these 25% and add, and this adds up to 25%. So if you look at it, 8% of this, of this whole thing were fetal death. That's miscarriage, stillborn. 2% were neonatal death. So, sick child, rule out sepsis, sudden death, or major malformation, sudden death. 15% were live-born and were ill or abnormal. Now, I had a few more cases in this past year's chapter, which is 2001, than 6 years ago. So the numbers are getting a little bigger. It's still not enough to make anything statistically significant. So I'm not trying to say that this is a definitive percentage. But if you look at all the patients that were treated with antibiotics versus the ones without antibiotics, there's some in here in the middle that they didn't say, so those aren't in these numbers. But 15 with antibiotic therapy, and this is dividing at any trimester, just with antibiotic therapy in pregnancy. The good outcome was 85%, 15% adverse. Adverse could be any of this. It could be something like prematurity, it could be something like hyperbilirubinemia, it could be something like severe rule-out sepsis, it could be death, it could, there's a wide range of adverse. Without antibiotics, it's really flopped over. So it's 67% adverse and 33% normal. So that again, is I think, suggestive, very suggestive that good prompt antibiotic therapy is very important. Now, when you're looking at when you're considering congenital acquisition of Lyme borreliosis, there are several other diseases that can either mimic that or that it can mimic. And this is just a list of all the types of things, congenital heart disease, sudden infant death, it's this thing called infantile multisystem inflammatory disease, immunodeficiencies, congenital viral, congenital syphilis, congenital toxo, bacterial sepsis meningitis. This would be the late form. And the early form is rather similar. But it's that when you have patients like this, it is very important to rule out the other diagnoses, because you certainly don't want to miss a diagnosis that you could be treating somebody differently for. Now, I'm just actually going to skip through these. This is just some suggestions as to what I would suggest if you're looking. But basically, you do serologies. If you can get the lymphocyte proliferative, that's nice. If there are any tissues that are going to be biopsied anyway, save them. If there's an LP that's going to be done anyway, save some fluid. Basically, save whatever you can and freeze it away on a patient that you think might have it, because you don't know what tests might come along that we might be able to make better use of. Now, this goes back to what I just said, that overall, what's very important in gestational Lyme is proper prompt diagnosis and proper prompt treatment. And I think if someone has prompt diagnosis and adequate treatment, and adequate means an adequate drug, an adequate duration, and an adequate dose, and it should be adequate for the stage and the severity of the Lyme disease manifestation. So someone with a single EM is going to be perhaps treated differently than someone with widespread disseminated EM and meningitis. And I think if in fact these guidelines are followed, then the prognosis overall is very good. In early Lyme, the prognosis is also, in early congenitally acquired Lyme, the prognosis also depends on prompt diagnosis. So if you have a baby that's born and starts crashing like one of the babies in the photographs, and if that baby doesn't get the right antibiotics, that baby may die. So it's important to include either cephalosporin or ampicillin or some sort of penicillin in the care of a baby that you might think in the neonatal period has acute Lyme disease. The prognosis in late congenitally acquired Lyme depends really on the state of any pre-existing irreversible damage that might have been done. So in the little boy that you saw so many pictures of, he had a lot of damage he still has a very mild, almost invisible right hemiparesis. That's probably going to be with him forever. He still runs, he climbs, he jumps, he plays ball. It doesn't hinder him in any way, but a neurologist can tell that he has it. And that was probably because it had been long-standing enough that it's just irreversible damage. So the prognosis will depend on what extent there is of any irreversible damage present at the time of initiation of treatment. And then I would stress this very much, that if you have patients that you think have congenital acquisition of Lyme, then it's very important to keep track of them in the long run, because we don't yet know how they might respond if they get reinfected. Okay. And now this is something that I actually wanted to launch here, so this gives me a good platform. And as you can see, we're talking about a disease that isn't real common. In other words, congenital transmission or congenital acquisition of Lyme disease. So therefore, we need a huge population base in order to catch anyone in that population base that might have either gestational or congenital Lyme, to be able to come up with good case definitions and understand more about the disease. So what I'd like to do is launch, and this will be up and running by July 1st, is a North American gestational and congenital Lyme disease study, called the WATCH. I'd like it to go for several years, maybe 5, 10 more years. I'd like it to be, the enrollment to be on the internet. There will be forms that are able to be downloaded so somebody can print them out, fill them out, and then type in the data from their printout back into the computer. And I'm not offering treatment on this, but I think what I'd like to do is try to get, there's going to be a prospective and a retrospective branches of this. One, so that let's just go over the objectives. The objectives would be to evaluate cases of gestational Lyme borreliosis and the relationship of various factors to pregnancy outcomes. That would be lab tests, antibiotic regimens, duration of the disease before treatment, severity of the disease, basically to try to figure out what's going on here. Second would be to evaluate the short and long-term outcomes, the infants, stillborns, miscarriages, products of pregnancies that have been complicated by gestational Lyme disease, and develop a case definition, both clinical and laboratory. This would eventually allow us to decide what we need to do. Oh, can you go back?
Yeah.
Okay. This would eventually be very important for management, but right now, I would say the bottom line is, if you've got somebody with pregnancy and Lyme, they should just get treated. They should get diagnosed and treated promptly, and then the baby should be evaluated at birth and followed. But this would, and so I have all these 3 websites. So basically, anything you think of that has to do with this, you'll probably not forget. So Lyme in pregnancy, gestational Lyme, congenital Lyme. I think this will hopefully catch everybody in North America that has anything to do with Lyme in pregnancy or Lyme in congenital situation. What I'd like to do is enroll. This could be doctor enrollment, patient enrollment, anybody. In other words, the internet is beautiful for this. Women with current or prior, acute or persistent. This gets the people with ongoing problems. This is the people with new problems. Gestational Lyme. Also, infants, stillborns, or miscarriages resulting from pregnancies complicated by current or previous, acute or chronic, persistent, anything. In other words, I'd like to get as many people giving this site information as possible. There would be 4 groups, 2 prospective, 2 retrospective. And from this, hopefully we'll get a few hundred patients in the next 6 months, and then from there, that'll be the beginning, and then I'll be able to further develop questions that we want to ask and things that we want answered on the website, and hopefully we'll be able to get some good information from that. Thank you very much.